Today we're getting under the hood of women's health with Dr. Andrea Braden, a dynamic CEO and founder of Lybbie, a revolutionary startup dedicated to empowering breastfeeding individuals. With her background as an award-winning board-certified OBGYN and board-certified lactation consultant, Dr. Braden brings a wealth of knowledge and passion to her mission of improving maternal health and wellness. Dr. Braden will be getting under the hood of pregnancy.
So I'm an OBGYN, which means I take care of women or people who are assigned female at birth. So anybody with a cervix, vagina, uterus, tubes, ovaries, those parts. And it's very broad. I would classify myself as a generalist, which means I do pretty much full scope OBGYN. So surgeries, office, delivering babies, all the things. As far as a subspecialty, I do also classify as a breastfeeding medicine specialist, which causes a little confusion for people. So I'll go into that a little bit. A breastfeeding medicine specialist is basically any physician in any specialty who does extra training in the science of lactation and breastfeeding. So in my scope, I went through medical school, trained in the whole human body, specialized to train in the traditionally female human body. And then I also did extra training in clinical practice, learning about the process of lactation and feeding infants with human milk. I loved taking care of women. I knew that. I loved that, the patient population is generally healthy, and that you have longevity with your care of these patients. So I loved getting to know people, hearing their stories. And to me, it was the ultimate non-decision because I knew that I could take this broad field of women's healthcare and do whatever I wanted with it. Generally speaking, there are two phases of pregnancy. There's like early pregnancy, which is the first 20 weeks. And then after that, it's kind of the later period of pregnancy. So I'll start with the later period because those tend to be the more common concerns that people are worried about. And that has to do with the age of viability being around 22 to 24 weeks, which means if the baby's born early or something happens, that's the age where we would do everything we could to help mom and baby and help baby survive. So that being said, the questions that we ask past 24 weeks or so is how's your baby's movement? That is the number one thing I tell people, do not take that lightly. I see so many women and parents who are pregnant telling themselves that, oh, maybe it's just me. Maybe I don't know how to feel the baby move. And that is a big red flag to me. And the worst case scenario is you'd come in, get checked out, and the baby's fine. And so what? You were safe. Because the worst case scenario is pretty bad. If your baby's not moving well, sometimes that's the only sign that something is wrong. And it is very time sensitive. Other emergencies that we look out for are bleeding in pregnancy. Bleeding can have lots of different causes, very common causes in the first trimester. And then in the second and third trimester tends to have to do with placental issues. And those can cause lots of pregnancy complications. So we always ask about bleeding. Are you having any bleeding? And especially heavy period-like bleeding, very abnormal. We would want to know about that. That is something to get looked at immediately. Breaking your water before you're supposed to break your water, breaking your water before your full term is cause for concern. And there are things that we would treat, especially under 34 weeks gestation. We would actually many times try to keep you pregnant if there's no sign of infection. But that is something you don't want to sit on at home and just, wait it out. Preeclampsia is a hypertensive disorder of pregnancy that can be very dangerous for mom and baby. And so when we're looking for those signs, we're looking at the effects of preeclampsia throughout the whole body. We take care of anybody who just needs somebody emergently in the hospital. That can be anything from decreased fetal movement to, I think I broke my water, or any other reason that maybe you don't even have a doctor yet and you don't know where to go. Those patients also oftentimes will come to what's called an OBED or a triage unit, which is where we kind of filter through, is this an emergency or is this, maybe something less emergent like a vaginal infection, discharge, or, an STD or something like that. But anything that you would come to the hospital for to get care is what I would see. Yes, when I have patients who come in labor, most of them deliver vaginally. I would say it's maybe 50-50, for my patient population of people who show up, whether or not they decide to get an epidural to help with that pain control or get other medications. But I oftentimes get patients who, came to the hospital for that distinct purpose. If they didn't want anybody inducing them or doing anything, and they show up in labor and specifically do not want anything done if they don't need it done. So it's across the board for my personal clinical practice. Things that I would recommend to really prepare is, I think what people don't expect is the exhaustion that happens right after you have a baby. It is called labor for a reason. It is, in most cases, a very physically taxing process, which means after the baby's born, you are really tired. And so if you can educate yourself and find resources before it's baby time, it can pay back, in multitudes, because you filed it away already. You have that information. So one thing I like to go over is, have you thought about whether or not you would like some sort of form of, pain control or something to assist with that? Or have you thought about whether or not you would like to have a birth without any pain medication or intervention? I try to have them kind of mentally prepare a birth plan. I guess you could call it that, but not everybody writes it down. Moms and people having babies kind of get left out of the picture, and that can feel very empty after having a baby, that you're like, what about me? I'm over here sleep deprived and struggling, and I can't get my breast to make milk, and I can't figure this out, and I can't sleep. The sleep deprivation is real too. So I think digging into your network, learning that it's okay to ask for help, and not the traditional help that you see in movies. In movies, it's like, give me the baby and I will feed it a bottle. That's really hard if you are one of the 83% of people who want to try breastfeeding, because that deeply affects your ability to make milk. So finding other ways to have people help you at the house can be clutch. Feed me, send me food, do my laundry, help me clean the house, so that you and your partner can focus on just adjusting to this huge transition in life. This is a topic that's very near and dear to my husband, and he's always trying to get me to add this content into my own Lybbie platform, because he has experienced this, and I think a lot of partners and dads and other parents, significant others, can end up feeling very unseen after the baby is born. What a lot of people don't know is that there have been studies, and I think they were limited to people who identify as dads, but there were studies that showed that 10% of fathers experienced postpartum depression. The other thing is, with partners, the focus was always on the couple, before, and now there's this other party there. Where do you find time for each other? And it feels impossible sometimes. So I think, we know that perinatal mood and anxiety disorders for, traditionally people who identify as female, um, are the number one cause of pregnancy related deaths right now, higher than hypertension, higher than postpartum hemorrhage. Pregnancy related deaths, the highest cause is perinatal mood and anxiety disorders. It is really a dire time right now, because if you've ever been in a relationship with somebody who is struggling with depression, anxiety, mood disorders, it can, trickle to the other person, to the support person. And I think it's so important to reach out to your support network. There are so many online support groups for this, especially even for partners. The thing is, everybody's labor is different, and it's highly dependent on your starting point. So what I mean by that is, some people go into labor on their own. Many people do not, for whatever reason. Some people break their water. Many people do not. So as far as let's say you're full term and you're ready to go. And many practices, because there were studies recently that showed that there was no downside to inducing people at 39 weeks. So for many reasons, lots of people choose after 39 weeks to go through an induction of labor. It helps with planning. Sometimes you got family coming, for whatever reason, some people want to induce their labor. And for those people, it depends on how open your cervix is. If your cervix is not ripe already, if you're not 3 centimeters dilated already as a starting point, and we need to do something, that can take 6, 12, 24 hours before you even get the actual induction started. And then, obviously if there's a surgical, intervention, a C-section, something like that, that changes the whole timeline too. And, that can happen maybe if labor is not progressing as we expect. And that might be because what we say is, it's either the pelvis is too small in relation to the baby, or the passenger, or the power, which is the contractions. So we use the 3 Ps to kind of figure out, why is the labor not progressing? And if all signs point to this baby is too big for this pelvis, that would be one of the most common reasons that we might elect to do a C-section instead of pushing forward for hours and hours. At the beginning, let's start with first trimester. Not everybody's excited. And I think we have to normalize that. I mean, I went from a time when I was in medical school where somebody came in for their first pregnancy visit and we were trained to be like, congratulations, baby, and not everybody feels that happy about it, and I think it can be really isolating to be the healthcare provider and not acknowledge and not try to read your patient and find out where they are, meet people where they are. So first trimester can also be complicated by some severe side effects. We all hear about the nausea and vomiting. I have people who become so depressed from the nausea and vomiting in the first trimester that they don't even know how they're going to make it to the second trimester. They spend so much time in the hospital trying to get treated. They literally cannot function. Both first and second trimester, there are weird symptoms that pop up that nobody talks about that make you very nervous. One of them being spotting. And when it's spotting, it's not like real bleeding. So you're like, what do I do about this? Do I need to call as an emergency? And even my sister, who's had 6 babies, who would call me all the time. She's like, I know it's nothing, but can you just tell me it's nothing? And that level of reassurance and the need for that is normal. That's normal. That's what we're here for. See, I'd say the other piece that is highly unaddressed and probably needs to be addressed more is feeding choice. How are you going to feed your baby? So, our training has evolved. Like at the beginning, it used to be you didn't even ask, and then it's like breast or bottle. Great, thumbs up. Now there's a big public health, initiative, and I don't. My experience has been, it's not that people don't know the information; it's out there. It's about choice. And then, I think being open to things may not go as planned. I think that's the reality too. And it can be really disappointing, deeply disappointing, especially if you've done all this research and you're like, I'm going to have a baby this way, and that's going to be how it happens. And I see a lot of depression being triggered by that as well. Just feeling very disappointed, like you did something to, cause this outcome, or maybe you didn't feel like you advocated enough, or maybe you just didn't understand well enough. And so I really think the safest way to go through pregnancy and delivery is to really equip yourself with knowledge. Ask questions. If you don't find that you are getting your questions answered, get a second opinion. That is also, you are allowed to choose who you see. You are allowed to feel supported, with your care. And so if it's not a fit, there are plenty of other places to go. The caveat being, don't wait too long. If you wait too long, it can be really difficult to find somebody to assume your care. But if you've been seeing your doctor and you're not feeling supported, trust yourself, listen to yourself. You can find other people.